I have nothing to disclose. Biliary disease in the elderly is an important problem because of its prevalence and potential severity. Yet the majority of the studies on the topic have focused on the outcomes of intervention, such as, for example, comparing laparoscopic to open cholecystectomy. So little is known about elderly all-comers who present with gallstone disease. The objectives of this study are to describe the differences in management of symptomatic gallstone disease within elderly age groups and to evaluate the association between older age and surgical treatment. This is a single institution retrospective study of all patients above the age of 65 who presented with an initial hospital visit for symptomatic gallstone disease within a 4-year time span. Data was collected on demographics, including comorbidities and diagnosis, as well as all surgical and non-surgical therapeutic interventions. For the initial hospital visit, as well as for all subsequent hospital visits over the period of 1 year. Patients were then stratified into 3 groups for descriptive purposes. There were 182 subjects in the 65 to 74 age group, 160 in the 75 to 84 group, and 55 in the 85 plus group. And these were our results. Diagnoses at initial hospital visit, stratified by age group. And you can see here that in increasing age groups, the diagnosis of biliary colic decreases, and in exchange, highlighted in green, is an increasing incidence of common bile duct disorders, up to 55% in the 85 plus group. Again, at the initial visit, you can see that in the older age groups, there's a decrease in the incidence of elective admissions for surgery. In exchange, many more patients, up to 3/4 of the patients in the older age groups, required medical or surgical admission following a visit to the emergency room. And this is probably an indication of severity of disease. This is probably the most important graph. This is the cumulative incidence of surgery over a 1-year time period following the initial visit. In the 65 to 74-year-old age group, almost 90% of patients underwent surgery. In the 75 to 84-year-old age group, this was down to 60%. And finally, in the 85 plus group, this is much closer to 20%. You can see that for all 3 groups, the greatest concentration of patients undergoing surgery were right at the beginning here, near their initial visit. In the 2 younger groups, there's also a lot of patients concentrated here undergoing surgery between 0 and 3 to 4 months, and this probably represents patients who had delayed cholecystectomy following initial non-operative management. What's interesting is that there is no such group here in the 85 plus group. The reluctance to operate on elderly patients following initial successful non-operative management is illustrated in these 2 graphs. On the left, the blue bar represents the percentage of patients within each group that underwent cholecystostomy tubes for treatment of their disease. In red represents the percentage of these patients who then had surgery. And you can see that that is quite low in both groups here following cholecystostomy tube. What's interesting here is the graph on the right. Again, the blue bars represent the percentage of patients that underwent ERCP, and this increases with age, and that's not surprising given the diagnosis profile that I mentioned before. What's interesting is that the incidence or the percentage of patients that then undergo surgery for their disease decreases sharply down to only 12% of patients at 85 and plus. We carried out a logistic regression with the dependent variable being surgery at 1 year and looking at age as a continuous variable, and found age to be an independent predictor of surgical treatment, and this was independent of comorbidity as well as disease severity. The data from this study must be interpreted in the context of some important limitations. First of all, this is a retrospective study, and the data was limited to hospital charts, which means that outpatient visits were not recorded. Furthermore, there was only a small number of patients in the 3rd group, and so this limits the inferences that we can make with respect to this group. And finally, there is a possible institutional bias, where our more conservative management of a more elderly patient may be something that's specific to our institution, not necessarily what is happening elsewhere. Nevertheless, I think we can conclude that older elderly patients presented more frequently with severe disease and underwent more conservative treatment strategies. Older age was independently associated with a lower likelihood of surgery. Our data don't allow us to determine whether these different management strategies are justified or not, but certainly this has sparked an interest in designing a prospective study comparing outcomes of operative versus non-operative management, and maybe more importantly, trying to determine what the factors are that influence a surgeon's management decisions with respect to this complicated and heterogeneous population. Thank you.
Thank you very much.